right. Hi there. All right. Good afternoon, everybody. Welcome to the session. We want to get started on time and respect everybody's time. So thank you for choosing our session to be your opening act for the plenary, the first plenary being the next one. And just want to get that excitement rolling, obviously. So yeah, welcome to Tips and Tricks for Running an Efficient Multidisciplinary CF Clinic. I just wanted to introduce myself and my co-chair. This is Barb McDonald, excuse me, I need to slow down. She is graduating from the LEAP program tonight, so be sure to congratulate her if you have the chance. She is a nurse practitioner with the University of Arkansas for Medical Sciences Adult CF team in Little Rock, Arkansas. And then my name is Beth Debris. I am a nurse and PEDS clinic coordinator or program coordinator. I work at the Coral Health Helen DeVos Children's Hospital CF Care Center, and I've been there for about 15 years now.
Good job.
This is the slide you'll be seeing a ton of this week, so we got to share that. As far as Barb and myself, we have no relationships to disclose. Also wanted to talk about the Q&A feature in the app a little bit. Be sure to use it. You got to find this session, and then at the bottom it says Q&A. Click that and type your questions in and hit submit. Something I did not know about is the voting feature. Helpful, just if you want to promote a question that you either have or think is a really good question, please use that voting feature. Okay, and then here are our objectives. We know that clinic days are crazy, and you might be stressed, and you might be overwhelmed or have a to-do list that's miles long. We get that, and we want that to, maybe we get some ideas here so it gets better. We do not want you to feel like that picture on the left. We want you to feel like the picture on the right. Easy breezy,
Right.
Able to connect with your patients and their families. We hope that this session sparks some ideas, sparks some things that you can adapt or adopt at your own centers, just things that work well for you. Also, we want everyone to, we are sharing generously so that we all can steal shamelessly. Also, here we go, contact us. Please do contact us if there's any questions or anything you want us to go into more detail about. I do notice that my direct office line is probably the better way to get a hold of me because I get emails that I just don't get from our system's firewall for whatever reason. So you can try and email me first, but if I don't respond, please do call. But we hope that you guys enjoy this session and get a lot out of it. With that, I'm going to introduce our first speaker. Whitney Gore is the nurse coordinator at the CF Care Center at Children's Hospital Los Angeles. She has been at the CF Center for 14 years. She'll be discussing the magic of pre-clinic preparation. Let's please give a warm welcome to Whitney.
Hi, everybody. All right. Are we all ready? After lunch, I know. Yeah. All right. Again, these slides you'll see, I have no disclosures. I do, however, have an unofficial disclosure. I am going to be talking about a very, very high-tech piece of equipment or program called Excel. And there's a reason why, and that is because we use Cerner, and I have zero way to utilize that for population management. So just getting that out of the way. Okay, so I'm going to set the stage. Whoops. Imagine you're in a busy clinic. It's your clinic day. Maybe it's in the middle of your clinic week. Everyone is showing up. Maybe there's some overbook. You are in the middle of running 65 different directions, trying to do all of the things, and the questions start. When did Sally last get her labs? Is this a quarterly visit or a follow-up? When did Sally have an abdominal ultrasound? Did Johnny start his modulator yet? When is he getting monthly labs? What are we doing about that? We're missing orders for throat culture. Is anyone else getting anxious? Because I am. Does it sound familiar to anybody else? Yeah? Okay. Thank goodness, because I ran a risk there. Like, maybe it's just us. Okay, so we've got all of these questions. So how do we go from the chaos of going in multi-different directions to feeling like organized chaos? Because let's be honest, there is no, I personally don't think there is a CF clinic that is not some sort of organized chaos, because there's just too many moving parts. And that's fine. But how do we do it and feel a little less overwhelmed by it? So, and one thing, so our CF Center took on a QI project to improve communication amongst our team in clinic. Our team has been together largely for many years. We are not shy about complaining to each other very outwardly. But we decided to do this in a way to try to quantify the grumbling and figure out the parts of communication in our clinic that just weren't working. And so we did an anonymous survey. We sent it out to the team, and you can see the results on the screen. 70% of our team was dissatisfied with the way that changes and updates during clinic were communicated. It's not good. 50% were largely dissatisfied or neutral with the way medication changes were communicated. And we have a 1-hour huddle that we have had, a pre-clinic huddle that we have had scheduled for years, probably 10 years. You would think by now we've dialed it in and figured out how to best use this time that everyone has been able to free up, and you can see that that is not the case. So what we found was that we had too many ways of communicating. Teams messages, Teams groups, like overdone. Emails, brief conversations, phone calls, carrier pigeon, got all sorts of different ways, and everyone was feeling overwhelmed. And again, while we had this weekly huddle, the majority of the team expressed dissatisfaction because a lot of people were, or perceiving that a lot of people were coming to that huddle unprepared to talk about patients. So I'm proposing that what makes pre-clinic magic is communication, and not just talking, but finding the right communication for your team and having shared responsibility. So again, I said, we have a 1-hour clinic huddle. We've had it for years. We discuss patients being seen the following week, and then we post huddle on the patients seen the week before, talking about did prescriptions get sent, did letters get written, kind of closing the loop on all of those. I send the list out to the team a few days before, and then this dedicated time, theoretically, providers are entering orders. We're entering orders for interpreter requests and lab coordination and child life, and trying to do all of as many things as possible prior to the patient showing up. And since COVID, this is what our meetings have looked like. Me, that is not me, but me and a sea of blank screens. And that was causing some challenges because there's a lot of interrupting that happens because you're not seeing each other face to face to get visual cues. Who knows? And again, our team has been together a very long time. My team members are some of my best friends, but who knows what we're all doing during this time. So what we decided to do was pull back our team meetings in person as best we could. We have a hybrid model because in the reality is there's no changing this remote aspect. So as many people, if you're in the building, you're in person. So we started there. So these are sort of what our meetings look like. And there are so many benefits to in-person meetings and communication. And I think COVID did a number. So, and there's so much research that's come out since COVID in terms of looking at the benefits of face-to-face communication, stronger relationships and trust building, better attention and focus, and increased productivity and collaboration. So now we're meeting in person, but the other thing that we did was that we are now having a strategic order of discussion for our huddles. And what I had heard from our team and in this survey was that some of the team members didn't feel like they were being given the space to share their updates. As a nurse, I can probably talk too much. Our providers would often cover the patient from start to finish and cover the RD material, what they feel like they knew of it, cover the social work material, and we weren't giving our team members and our colleagues the space to freely share. And so I give a brief introduction to the patient, and then I ask the RD specifically, do you have any updates? The RT, the social worker, the pharmacist. And then the provider closes it out with anything additional and things from their perspective. And then we also started the creation of the spreadsheet. We don't have a fun, fancy name for it. We should. But this is what that looks like. I'm going to break this down, but I just wanted you to see the massive as it is as a whole. So this started as a spreadsheet that I created when I first started in the CF Center many years ago, because I was just trying to wrap my head around how do I keep all of this stuff together. During our QI meeting, so we did the survey, we got our preliminary results, and as we were meeting to sort of fishbone and talk about ideas about what would our potential interventions be, one of our dietitians, Angel Jones, had the idea of why don't we modify this spreadsheet to make it a living document that the entire team can add their plans to, and it all is contained in one spot. Yes, we all write clinic notes, but I don't know about anyone else's clinic notes, but to really find the highlighted portion of that note, there's a whole lot of scrolling, there's a whole lot of digging, and a whole lot of combing through. So we decided to kind of make a shortcut. So the weekly list of clinic that I send out it's essentially copy and pasting into a document from the master into a weekly document that's titled with that week's date. That gets sent out to our team members, and that is what we use to guide our discussion for our pre-clinic huddle. At the end of a week, so we've seen all the patients, we've updated this great spreadsheet. At the end of the week, I'm then copy and pasting back into the master document. Does this take a lot of time? Yes. But it has really proved that it's worth that amount of time in kind of just and you'll see later that it's working for us. I do give the team up until Friday to make any of their updates, because things happen and clinic gets busy and you don't always have time to completely update it. So we give each other a little grace. And so this is essentially the part that got added. So each provider has a column for each patient, and they add their bullet points, their updates from clinic that day. We're still working with each other to maybe not write quite so much, but we're getting there. But it also has updated that clinic's visit, the FEV1, their BMI, their weight, and then updates from the whole team. If the team member doesn't see the patient for whatever reason, they just write did not see. And then in post-clinic huddle, that allows us to circle back to find out why they didn't see the patient. Is there an opportunity for follow-up after the visit? And kind of just discuss along those lines. Okay, so we did all this work. We're utilizing a spreadsheet. It's a lot of information. It's a lot of copy and paste. Did it work? It did. So you can see here the pre and the post. So changes and updates during clinic went from largely dissatisfied to all neutral and positive. 78% of the team are now feeling satisfied with how we're communicating. Medication changes increased as well, and you can see satisfaction with pre and post huddle has all green responses. So maybe you're saying, okay, this is great. I don't have time, nor do I really want to take the time to create this massive spreadsheet. CF Smart Reports has a couple of already created potential documents. There's the short report and the long report. They hold true to their names. The short report is 1 page. The long report is a couple of pages depending on the complexity of your patient. These can be used too. What I really want to drive home is that this isn't necessarily about having a great spreadsheet or using the smart reports, but it's working as a team to figure out together what your interventions could be for your team and how they would best work. Would a spreadsheet work for a clinic of 400? Probably not. Maybe, but probably not. I don't know if I could keep up with it. We have about 140 patients, so it works. I can manage that alone. I can manage that. But I think really the most important thing for kind of this pre-clinic magic is working together as a team to figure out how do you guys best communicate and share the information amongst each other in a way that feels right. So we're back to clinic. You're back in the middle of it. going crazy. And instead of all of these questions about who needs what and what is happening, now it's feeling a little better. So someone says, oh, Sally's labs were done in July. We don't need to do them now. I'm excited to see Johnny for his quarterly visit. We know when Sally's last abdominal ultrasound was. We can assign who needs to follow up on that. We know when labs are going to happen. Throat culture orders were entered appropriately and the nursing staff doesn't have to go crazy. That's just me, or our staff. Sally's vitamin D, everyone knows the answers to all of these questions. And things feel just a little bit better. I want to say thank you to my amazing team. I have the honor and the privilege of presenting the work that we did together. None of this it's not my work alone. And I really, really encourage everyone to take the time, survey your own team, whether it's anonymous or everyone puts their name on it, to really find out where your pain points are and address them directly. But working together really is what the magic's all about. So thank you so much. I appreciate your time, and I'll take any questions.
I have one for you. You indicated that you sent. Oh, microphone.
Hi, thank you. So you indicated that your team has until Friday afternoon to update the master list, and then the following week, I'm presuming that you will review that for your post-clinic huddle. Do you have Friday CF clinics?
Not officially, no.
Okay.
Not officially. I think
Okay.
the day isn't necessarily, that was our arbitrary, here you go. Oh, sorry. That was kind of our arbitrary kind of cutoff, but
Sure.
unofficially, no, we don't.
Just trying to think through how you make that happen in a center where there's CF clinics.
Every day.
Every day of the week, yeah.
Yeah.
Thank you.
It's usually, even in our center where I don't have CF clinics, it's usually late in the day to make it happen. All right. Thank you.
Thank you so much, Whitney. That was awesome. Next up, we have Sarah Siciliano. She is a registered dietitian for the pediatric CF program at Corewell Health, Helen DeVos Children's Hospital. She has been a part of the team or the Helen DeVos team since 2022. She will be discussing how their team implemented an electronic approach to improve clinic flow. Come on down, Sarah.
Can everyone hear me okay? Yeah, okay. Well, thank you so much for the kind introduction, Beth. As mentioned, my name is Sarah, and I'm really excited to share our team's work on transforming our CF clinic workflow through the use of an electronic process control board. Similar to Whitney, we have a love for an Excel over here, and this project was truly a collaborative effort made by our incredible CF team, and it really reflects our shared commitment to improving delivery and communication in a complex clinical environment. I have no disclosures to share. Before we dive into the details, I want to walk through the main objectives of today's presentation. First, we'll explore the communication or coordination challenges that arise in a busy CF clinic, especially when multiple disciplines are involved and patient needs are constantly evolving. Then, I'll show you how we addressed these challenges by implementing an electronic process control board. The tool not only streamlined our workflow, but also improved access and accountability across the team. And then finally, we'll look how visual reminders embedded in the board and elsewhere within clinic help us stay on track with the completion of quality improvement initiatives. This is our incredible CF team, made up of 16 distinct disciplines, each bringing specialized expertise to the table. As many of you know, one of the greatest strengths of the CF care model is this breadth of knowledge and collaboration. But with that strength comes some complexity. When multiple disciplines are involved at every visit, coordinating care efficiently becomes a real challenge. Without standardized workflows, we risk miscommunication, missed tasks, longer than necessary clinic visits for our patients. That's why establishing clear, consistent workflows has been essential, not only to keep clinic running smoothly, but to ensure that every patient and family receives coordinated, compassionate care that aligns with their individual needs and priorities. Before we moved to an electronic system, our team relied on a dry erase board in the conference room to track clinic flow. During weekly huddle and clinic prep, the board would be filled out for each patient. We included details like scheduled clinic time, which provider would be seeing the patient, and which disciplines planned to be involved. We used a simple color coding system, green for yes, blue for maybe, and red for no, to quickly communicate who was planning to see each patient. The board also captured pending items such as annual labs or OGTTs. Once patients were roomed by the MAs and completed PFTs, if age appropriate, the flow of the visit was tracked directly on the board. The first screen discipline would write their start time, and when their visit was finished, they would record their out time. At that point, they would complete a warm handoff to the next available blue or green discipline. This process was used in our clinic for many years, and overall it served us reasonably well. One clear strength of this system was that it built in warm handoffs directly into our process. The expectation was clear that when you finished your visit, you connected directly with the next discipline that was due to see the patient. This also gave the clinic day a predictable rhythm. Everyone knew the general order in which disciplines would see patients. First pharmacy, then social work, dietitian, provider, and so on, which really helped create consistency and flow. One major drawback of the whiteboard system was its location. It could only be seen in our conference room. This created challenges because not all members of our multidisciplinary team are based there during clinic days. In fact, a large portion of our CF team, including RTs, MAs, dietitians, social workers, and providers, are housed within the larger pulmonology clinic and don't always sit in the conference room with the rest of the CF team. As much as we would love to have everybody together in one space, physical limitations make that really difficult, especially on busy clinic days when we have residents, interns, or students joining us as well. This ultimately meant that that a good portion of our team did not have real-time access to the whiteboard, which limited their ability to know where patients were at in their clinic visit. Beyond limited visibility, we also faced challenges with preserving information from the board once clinic ended. Our nurses would do their best to take photos of the board after clinic, but we didn't have a great process on how to organize these or access it later on. There were also struggles with consistency. Sometimes disciplines would forget to check in or out, which made it difficult to track where the patient was at within their clinic visit at any given time. Combined with that limited visibility, this often led to delays and increased patient wait times. Lastly, as our QI work expanded, so did the numbers of screenings and reminders needed to track for each patient, and trying to capture all of this on the board made it very cluttered and messy, which ultimately limited its usefulness. While the logistical challenges were significant, the real turning point for us came when we recognized a deeper gap: our inability to consistently track what mattered most to our patients during their clinic visits. We've always known that agenda setting is a cornerstone to patient and family-centered care, but despite our best intentions, we didn't have a reliable way to capture those goals and share them across the entire team. We initially tried to have our MA team record the patient and family priorities in the provider's note within Epic. However, this wasn't very effective since the note wasn't routinely accessed by all other disciplines during the clinic visits. And as a result, patients' goals and concerns were often missed. That experience pushed us to rethink our approach and create a shared tool that gave the entire team easy access to what mattered most to our patients, no matter where they were at in clinic. To do so, we relied heavily on the CFLN's reliability framework to build a more reliable process. One key insight was that our old system relied too much on memory and vigilance, making consistency hard to achieve. So we built in more standardization and added visual cues, especially for agenda setting and QI screenings, to ensure priorities and tasks were clearly visible in one central location for each and every discipline. The framework directly shaped our electronic process control board, helping us shift from a system based on individual effort to one that supports team-wide reliability. So, in June of 2024, we transitioned from our dry erase board to an electronic process control board, or EPCB for short. And this was to improve clinic flow and better support our QI work during CF clinic visits. The electronic process control board is housed in a shared Excel file, giving every discipline real-time access, whether they're in the conference room or working elsewhere within clinic. It preserved everything that we liked about the whiteboard, but added new features to enhance coordination and data tracking. Team members can update it live, and that updated information is instantly visible across clinic. Most importantly, it functions as a living document, allowing us to continuously adapt it based on our current QI priorities and evolving clinic needs. To make weekly updates easier, we built in drop-down lists for key details like patient room numbers, provider assessments, CF RISE options, and this helped to ensure consistent formatting and makes the board quicker to use. We also added drop-downs to track whether a patient is due for a full PHQ-9 and GAD-7 based on our mental health iLab participation or DEXA screening. This allows us to consistently identify and address key QI screenings. For documenting time in and out, we use a simple Excel shortcut, Control-Shift:, which autofills the exact time. This small change has made time tracking faster and has improved consistency across the team. Altogether, these updates have made the electronic process control board more user-friendly, standardized, and reliable, while reducing the burden of manual data entry each week. Next, we'll walk through a video example of how a patient is entered into the electronic process control board. For this demo, we weren't able to use my favorite shortcut of the auto-filled timestamps, but in practice, that feature really does make time tracking much faster and consistent across the team. So first, an MA would list what room the patient is in, so everybody's aware, and then clock their in and out time. Once they're done, if the patient has any agenda settings they would like to share with the team, they would list them there. And then they would move to the next green discipline, which is typically pharmacy. Once they're clocked in and out, they would again move to the next green discipline, which in this case was the dietitian. After the dietitian is done seeing the patient, it is then their responsibility to initial that they have addressed the agenda setting item. And that is so that we know and can ensure that all of the patient's needs are addressed. And then continue to move on to the next available disciplines. To understand how the electronic process control board was working in practice, we sent out a survey to our CF clinical team. We had a great response rate, as over 85% of our team completed it, and one of the most encouraging findings was that 96% of respondents said that the electronic process control board was just as easy or easier to use than our previous dry erase board, which showed us that the shift to a digital format didn't compromise the usability of the program. Real-time access, reliable agenda setting, and better provider communication were among the top benefits cited by our team, directly reflecting the goals that we had in mind when building the board. Beyond the benefits highlighted by the team, the electronic process control board also helped us advance our QI work. As I've already mentioned, the built-in reminders for key screenings like CF RISE, PHQ-9, GAD-7, DEXA, and modulator use to support side effect screenings. The board improves visibility for what's due for each patient, and we've seen stronger completion rates of QI initiatives during visits. It's also helped reduce the risk of missing or delaying important assessments. One of my favorite functions is also the notes section, which has become a flexible space for tracking miscellaneous projects and follow-ups as needed. As mentioned, one area where the electronic process control board has showed some measurable improvement is DEXA scanning. It's important to note that most of the gains in 2023 came from other targeted QI approaches. However, the electronic process control board has helped play a key supporting role by keeping screening needs visible across the team, even as our active focus has shifted to other initiatives. The board's built-in reminders has helped maintain momentum, reducing missed screening opportunities for CF-related bone disease, which has allowed for continually increasing DEXA completion rates into 2024. The next slide shows our progress with agenda setting, specifically the percentage of patients of whom agenda items were both collected and addressed during clinic visits. The electronic process control board has helped support this effort by making agenda tracking more visible and accessible to the entire CF team. It has helped us consistently capture input from patients and families, and has also improved follow-through by prompting providers to address those items during the visit. While we haven't reached perfect consistency, the upward trend reflects meaningful progress. And as we continue refining our workflows, the electronic process control board remains a valuable tool, not just for initiating agenda setting, but for sustaining it as part of our routine care. This slide shows our mental health iLab data, specifically tracking completion and the full PHQ-9 and GAD-7 assessments. Similar to our agenda setting outcomes here aren't perfect, but the electronic process control board has been a key support tool. At Helen DeVos, it is standard practice to administer a PHQ-4 for patients over the age of 12 at every clinic visit. The electronic process control board helps our MAs quickly identify which patients are due for the full PHQ-9 and GAD-7 and whether those assessments will be completed by our psychologists or medical social work team. Having this information available on the board has also helped reduce the duplicate screenings, ensuring patients don't receive both the PHQ-4 and the full assessment unnecessarily. And it's a great example of how the electronic process control board supports coordination and consistency in busy clinic settings. An unexpected but meaningful benefit of the electronic process control board is reduced downtime between disciplines during clinic visits. While minimizing provider-to-provider gaps wasn't a primary goal when we implemented the board, the data shows a clear improvement. With the dry erase system, the average downtime between disciplines was about 6.5 minutes, and after transitioning to the electronic process control board, that dropped to under 5 minutes. This likely reflects better visibility to patient flow and provider availability. The board helps the team stay coordinated in real time, which naturally reduces delays even without direct interventions aimed at downtime. It is a great example of how thoughtful design can create ripple effects that improve efficiency across the clinic. As with any new system, implementing the electronic process control board came with a learning curve, and this slide reflects some of the key lessons we gathered along the way. We found that frequent reminders and periodic re-education are essential, even though with a thoughtfully designed tool, maintaining consistent use requires regular reinforcement and support. For example, our core CF team members use it regularly, but areas like GI or endocrine who aren't in clinic as frequently have been less consistent with their use. Workflow consistency is something we continue to refine as well. While check-ins and outs and warm handoffs aren't always completed reliably, the electronic process control board has made it a lot easier to close those gaps. With real-time access, any team member can quickly ask the next discipline to clock them in or out during a warm handoff, making coordination more seamless and reduce missing transitions that can affect patient flow and communication. After seeing the positive impact in CF Clinic, we recognize the potential for this tool to support other complex multidisciplinary clinics. It has since been implemented in our ventilator clinic, neuromuscular clinic, and aerodigestive clinic here at Helen DeVos. Each of these clinics have unique workflows, and so the boards have been customized to meet those. This adaptability shows that the electronic process control board isn't just a CF solution, but it's a flexible framework that can strengthen efficiency and patient-centered care in a variety of settings. Beyond the electronic process control board, we built in visual reminders directly into our physical clinic space to support screening reliability. Since we share a floor with 5 other clinics, we use reserve signs to ensure that CF rooms are readily available as soon as patients arrive. To make these signs more functional, we've added removable Velcro icons that serve as quick screening prompts. For example, we have a bone for DEXA, a virus for flu, ACT for asthma control testing, and PHQ for mental health screening. These cues are simple, visible to the entire team, and are easy to act on. They've helped us avoid missed screenings, especially in a busy flow of clinic when it's easy to forget what's due after gowning up and walking to the patient room, even if it was identified on the patient or the electronic process control board first. Our final visual cue is one that many of you are probably familiar with, and that's room flags. While simple, they've maintained an effective tool for real-time communication across the team. In our clinic, red indicates that the patient is ready for checkout, white signals nursing, green is for the provider, yellow marks specialty staff, blue means the patient's in the room, and black indicates a clean and empty room. These flags help us quickly understand room status at a glance and coordinate transitions more efficiently. When used alongside tools like the electronic process control board and our Velcro screening prompts, they round out a system of visual supports that help keep our clinic running smoothly, even on the busiest of days. If you are interested in implementing the electronic process control board in your own clinic, I'm happy to share a master copy and our step-by-step setup guide. This tool has helped us improve reliability, reduce missed screenings, and streamline communication, and we've learned a lot along the way. So whether you're starting from scratch or looking to refine an existing system, we're glad to support your efforts. And feel free to reach out to me directly at the email listed here. I'm excited to see how other teams adapt and build on this work. Finally, I just want to say thank you. This project wouldn't have been made possible without the support of the Cystic Fibrosis Learning Network and the funding from the Cystic Fibrosis Foundation. I'm especially grateful to Dana Reckley and Dr. Johanna Zia Hernandez for their countless hours of help and support throughout this process. It has been a team effort from start to finish, and I'm proud of what we built together. Thank you for your time, your interest, and your commitment to improving care for people with CF. Okay, and I'm ready for any questions.
I kind of have two questions, sorry.
for it.
So I'm not big on Excel, so was this whole thing created in Excel?
Yes, yep,
Okay,
a lot of Googling.
okay. And then did it live in like just a file on a computer and you guys kind of all just went to a computer?
So we have Outlook as our kind of, system that we use. And within that, we have files that the whole team can access if you're a part of a certain team. And from that, we're all able to open the electronic process control board. It can either open in a browser or you can just, kind of have it saved on its own. And then everybody kind of normally has it up in a browser during clinic. And then you each have your own version of it, depending on where you're sitting.
I'm just wondering, do you think it could be something you could use on like an iPad and kind of like pass off to each other?
Yeah, I don't see why not.
Okay.
One of our favorite parts, though, is that like no matter where you're at, you can see it. But I think that could be a great utilization of it.
Thank you.
Yeah.
Okay, so
There's one really quick question.
go for
Can it be accessed in the patient exam rooms?
So it can be accessed in the patient exam rooms. I don't know about you guys, but logging onto those computers is like especially slow. So that is one of the limitations. Our MAs are normally having to wait till they're back to their desk to kind of enter in the information that they have for agenda setting or other notes and things like that, but it can be accessed.
Also, you mentioned earlier that it flags for if a kid needs something. Where does it pop up? And how did you?
Do you mean like the agendas?
Yeah.
Yeah, so once the MA is done rooming the patient and they can ask, if they have any items that they want to have addressed or any concerns shared, they will just add that to the agenda setting portion of the electronic process control board, so it's built directly in there. And then we have it so that as you're scrolling down the screen, no matter what discipline you are, that first portion of the Excel sheet will follow through so that you're not losing track of that too.
all right, so you had a question that. Sorry, can you all hear me? Yeah. Thank you. I'm trying to go in order here, so just give me a sec. How is the electric process control board created?
Created in Excel. I don't really remember how we started. I was the one to initially kind of develop it, but we do a lot of our other tracking for QI projects just in Excel. So I kind of thought, how can we track all these other things that we need, including the clinic visit? And I just tried to copy what we had on the whiteboard while being able to add those extra items that were missing.
All right, and then Ally asked, how do visit agendas work? Do you ask the patients their family concerns at the beginning of the visit? Do you have the MA address any concerns during Vital-In? Or are visit agenda concerns from provider staff to address during clinic?
So we utilize it mostly for the patient's concerns that they want to address during the visit, so that we're making sure that clinic visits are based on what they want, considering they're there for multiple hours, multiple times a year. So we'll have that listed there. Typically, if it's kind of like a vague one, the MA team will maybe put like RD or RT or provider next to it, just so that the staff knows who exactly needs to be addressing it. And of course, when you're in, clinic visits, patients will sometimes bring up that concern to you as well, and you'll kind of address it there. But it's just a way that we can kind of see those concerns and prep for them before we go in to see the patients.
Katie asked, do you have an EMR, and are you able to build this control board into that?
Yeah, so we do have Epic. I don't know, probably.
Abby asked, do you integrate the EPCB into your pre-clinic round-in huddle as your team prepares for clinic?
No, but listening to Whitney, I'm very inspired of the things that we can kind of mesh together to have both of them exist.
Rebecca asked, how do you enforce communication through the board during clinic and not through other back channels like EHR charts?
So we definitely are communicating a ton still through Teams and just, handoffs and things like that. Just a lot of reminders, especially in the beginning. We would just send out things of remember to use the electronic process control board, remember to initial if you addressed an agenda setting, just lots and lots and lots of reminders. And our team is doing pretty great with it now.
Olivia says, I love that you measured down time. How did you track this metric? And we've had trouble measuring this in the past with this. Great work.
Thank you. So we had some photos of the old dry erase board, and so we just kind of looked at when one discipline checked out, how many minutes was it until that next discipline went in to see the patient, and then we just compared those numbers on the new board too, and we're able to find out that we are seeing kids much quicker. And unfortunately too, when I was doing this data with the help of Dana, there was just a few outliers that were like really long kind of dry spots in the electronic process control board that kind of like skew the numbers. But I think on a regular, clinic time when we're flowing good, it would even be significantly less time in between disciplines.
And then the only question I had with the Excel sheet, do you have it locked so that you're still protecting patient confidentiality?
Yeah, so the shared drive that we have all of our files on in clinic are protected. We try to not to have like a full patient name on there, normally just like an initial and a last name, or the first name and a last initial, and then there's really no other identifiers. Any other questions?
I have one. My app won't let me ask the question.
Oh, no.
I loved your presentation. We have the big whiteboard, probably like a lot of centers. Do you have the electronic Excel sheet visible in clinic, or is it on everybody's individual computer screens?
So we really loved the idea of having a big one visible within the conference room as well, but we found it really difficult because someone needed to be logged in to have that displayed, and typically it was our nurses just because they're the ones kind of really running clinic. But then when they would go in to check out patients, it wasn't allowed to be up just for protection reasons, and so we can't have that.
So just on your individual.
Yeah. Anything else? No? Well, thank you.
Thank you so much, Sarah. That was amazing. Next up, we have Jill Fleeke. She is the program coordinator and nurse practitioner for the adult CF program at Nebraska Medicine in Omaha, and has been in these roles for almost 25 years. Wow. She will be sharing three team strategies. That's a hard word to say. That their team uses to implement in their clinics to improve clinic flow. So take it away, Jill.
Thank you.
All right, good afternoon, everybody. I wanted to thank Barb and Beth for inviting me to speak in this afternoon symposium. As mentioned, my name is Jill Fleege, and I've been in the dual role of the program coordinator and nurse practitioner for 25 years. So you can imagine over 25 years, you see a lot of things that change with your clinic flow. A lot of things that you can't control, so you try to control what you can. And one thing that is constant is that there's always room for improvement. I marvel that I've been doing this long, and I think I have everything finally down, and then I open an email and something changes. So change is constant. So what I'm going to do today is I'm going to share 3 team strategies that we currently implement in our current clinic at Nebraska Medicine. And the emphasis on my strategies is team. And so all of us know that in order for us to have what we call a successful clinic, as successful as we can, it really takes everyone's input as our multidisciplinary teams just get bigger and bigger. I have no relationships to disclose related to this presentation. A successful team can be a group of many hands and one mind. I've found this cute little picture. For the CF team, the many hands can be all the disciplines that are involved in a patient's clinic visit. And when you talk about the one mind, I think we'd all agree, we're all in one mind that we want to address the patient's and family's needs when they're in clinic. We want to address our own needs of what we want to talk to the patient about, as well as what the CF Foundation needs for us to complete during a clinic visit. And do all that in a mode where we're respectful of the patient's and family's time in a decent length of a clinic appointment. As I go through my presentation, I want you to pay attention to the words that I have highlighted in pink. For example, on this slide, it's the word team, because that will kind of highlight which team members are involved in these strategies that I'm going to present. So as I was trying to figure out what did I want to present today, the word adaptability kept coming to my forefront. And when I think about CF teams, there's no two teams are the same. And I wanted to try and present some strategies that we do in our clinic that you could apply whether you're a peds program, an adult program, whether you're a large center or a small center with many patients or many multidisciplinary team members. And also these strategies that you could try to implement within the physical constraints of your clinic space. There are so many things to think about. So the 3 that I'm going to present today are a clinic map that we use to minimize wait time for our patients, a personalized CF appointment agenda that helps prepare patients and staff for the visit, and then I'm going to talk about how our CF nurse and provider in our case is either a nurse practitioner or a physician, how they have a partnership in clinic which helps to increase efficiency in clinic. So the first strategy I wanted to present actually was clear back in 2018, 2019. And what we do is we use a clinic map to help minimize wait times. And this was born out of some quality improvement project that we did in response to data we received back from the patient and family experience of care. So if you've been around since 2018, that's an old survey. It was replaced by the current experience of care survey, which if you haven't heard, if you haven't opened your email, the experience of care survey is going away at the end of this year. So, but getting back to this one, this is the PFEC. So one of the metrics that were asked of our patients in this survey was whether or not they were brought back from the waiting room to the clinic room in a timely manner. And you can tell from this slide that we got a result of 22, which put us below other CF programs. And like most people, that did not sit well with us, so we embarked on a QI project to try to change that metric. So what we did was we developed these laminated clinic maps to help minimize waiting room times. As you can see in this picture, I'm glad this is a fairly small room. This is actually one of our maps that we use, so you can kind of see the physical map that we use, not just a picture on my slide. And they're laminated, they're green color. And Barb's going to look at it. But it's a diagram of our clinic space, and we have maps for different clinic days with the rooms that we're assigned. We don't have the same rooms every day, and we don't have the same number of rooms every day. It depends on what day the clinic is, how many providers we have. And so we have a map for every clinic day. For example, this map here says that on Mondays and Wednesdays, the CF team gets room number 7. And so what happens is the medical receptionist out at the front desk has lays out the maps, say for Monday. Monday we have rooms 1, 3, 5, and 7. So she has those 4 maps laying at the back of the reception desk. And then the patients are brought back by the front desk receptionist right after check-in with this laminated map. We have to have badge access to get back to our clinic space, so that's why the medical receptionist actually gets up and takes the patient back. The clinic map is in place. We have plastic trays on our clinic doors, and we put the map in there, and that signals the medical assistant then to grab the patient and do the rooming process. When we are done seeing the patient and the room is clean, the map is grabbed from the door and walked back to the receptionist, and then we know that that room is then available for the next patient that needs it. So within a year of implementing this process, our results improved from 22% actually to 100% of patients feeling like they were brought back to an exam room in a timely manner. What is amazing to, I think, all of us on the CF team, that was like 7 years ago, and this process is still being used in our clinic space today, even with all the staff turnover of the medical assistants and the medical receptionists. And I will tell you, it's probably one of the best QI projects that we've done, and patients love it. All right, the second team strategy I'm going to present that we actually just started using this this year. It's called a personalized CF appointment agenda. And this agenda also was born out of some comments that we received from the current survey, the Experience of Care survey, where patients were wanting to kind of get an idea of who's all going to see them in clinic, what tests are they going to have done. And so we came up with, it's a front and back personalized CF appointment agenda. The front side is the patient's agenda, what they want to accomplish during the clinic appointment. And then on the right side is the CF team's agenda. And I did, if you go into the app for this talk this year, I think it's new this year, I haven't spoken in a couple of years, we could actually download handouts, so you can actually access this handout on the app. I also do have physical copies that I brought, if anybody wants to come up and grab one after the appointment, or after the presentation, excuse me. So I wanted to break it down because obviously you can't see that from the room. And so I'm going to break down the different parts of this form. So the first part will be the patient's agenda. So that's on the front of this sheet. And we put the patient's initials just so we can keep them straight. And then we just have a very simple question that we ask, an open-ended question. What's important that we know about your health today? Sometimes that's answered, sometimes it's not. Sometimes they're just there because they need to get their lab to get their Trikafta. So they may or may not answer that one. The next part of the form is we have all the providers listed, and the patient can actually check if there's a certain provider that they want to see. And we all think it's important that they have their names of our providers because it's important for them to learn our names, especially if they're new or transitioning from the PEDS program. And then in red, we have different topics that particular discipline might be the person that you ask. So for example, I'm going to pick on Laura Romero, our social worker here in the front row. The fourth one down, if they want to see Laura, they'll check the box, and maybe they want to talk to them about a new job that they got. We also have lines if none of those apply and they have a whole different topic that they want to fill out. The other thing we have put on this form is the food insecurity questions. There are 2 questions here that we ask. Again, it's on the patient agenda side. In the past 12 months, I've worried whether my food supply would run out before I got money to buy more. And in the past 12 months, the food I bought did not last and I did not have money to buy more. We've always wanted to try and incorporate these questions in a QI project. We just hadn't gotten around to it. So when we were developing this form, our dietitian rightfully thought, why don't we put it on this form? And that way we're asking it every clinic appointment because, if you do it once a year, I think our clinic or our patient's situations can change from clinic appointment to clinic appointment. So we added that also to the form. And so I won't go back there, but if they happen to answer anything, but it's not a problem, we then get our dietitian and our social worker, we notify them, and they will go in and talk to the patient and provide any resources and dig a little bit deeper into why they're having problems with food insecurity. All right, and then the back half of the form is actually what we as the CF team want to accomplish. And so we will, when we hand this form to the patient, it's already marked who of the patient or who of the team members want to see the patient. Again, we have their discipline and their names. And then the bottom half of the form, we've already marked, because we've done clinic prep, that's how we find out what they need, what they're going to get accomplished during their appointment, hopefully, whether that's lab, mental health screening, our physical therapy, annual testing, sputum cultures, PFTs. The three I want to point out are toward the bottom, the oral glucose tolerance test, the DEXA, and the abdominal ultrasound. Sometimes that takes some planning. It may not be done that appointment. Maybe this appointment, we're going to tell them that your next appointment, you're going to have that done. And so we're still tweaking all this, but in general, we have just had some really good feedback from our patients that they like, to know what's kind of coming. So how do we actually implement this now that I've kind of showed the form to you? So each member of the multidisciplinary team actually completes a team document where they state which patients they need to see for the next week's clinic. So we're always working a week ahead of time. And the deadline to get that noted on the team's list is 9 a.m. the week before the clinic that we're talking about. Then it's our CF nurse's job. They still do telephone reminders where if they happen to get the patient, they'll say, this person needs to see you, you need to have a chest x-ray. But as you know, we don't always get a hold of the patient and we don't like to leave a lot of information on their voicemail. So in this case, at least the agenda that we're going to give them on clinic still gives them a sense of how the next hour and a half to 2 hours is going to go. So it's the CF nurses who fill out the agenda, the CF agenda side, on the form before clinic. And then in our center, after the patient gets checked in the room, the CFRT is the first CF staff that see the patient. So they actually hand this form to the patient with a pen, and the patient then completes their side of who they want to see and the food insecurity questions and answers that general question at the top. And then I'm going to talk about this next, but our nurse and our providers actually see the patients together. They review the agenda when they see the patient and then address any needs or staff requests to make sure that we've paid attention to what the patient wants. All right, and then the last one I'm going to talk about is how our nurse and our provider work together in clinic. And this has two components of our partnership that I wanted to share. Our nurse and our providers, whether that's the nurse practitioner or the physicians, they actually see the patient together for the entire visit. And this is probably out of the three I presented has the most caveats that may or may not work for every CF center. I acknowledge that. But if there's something about it you like, maybe there's some tweaking that you can do. In order for this to work, we use the computer in the room, so it's important that there's a computer in the room. And the reason for that is because the nurse and the provider work together to complete the clinic note. We have Epic, so again, that may or may not work for everybody, but maybe your electronic record has some way that you can tweak it. And I'm going to go through how we build the note between the nurse and the provider here in my next slides. But the nurse starts the note, and then the provider takes over the note during the clinic and completes some parts, becomes the author, and signs the note after the visit. So here's just some screenshots. This is not an actual patient. You can see the name is James Lung, RN, Aerosmith. I did not come up with that. We have they call it the playground where you can, kind of play around in Epic, especially if you're a new employee trying to learn it. But this is actually a screenshot of what it looks like to us when we're actually sitting in the room with the patient next to us. And when Epic was started with us, we had built in different templates for different notes. In this example, what happens is the nurse actually sits at the computer first, goes to the clinic schedule, clicks on a patient's name, and in this example, she's going to open up a routine visit, which you see here on the right side. Oh, shoot, I can go back. And the nurse is responsible for the first part of our clinic notes. So they'll fill out the visit type, which this will drop down to like a routine visit, a quick follow-up, hospital follow-up. We also keep track of what room the patient's in, for infection control issues. So, you know, thank goodness we've never had this happen, but if there ever was an outbreak of a certain, bug in our center, we could go back and see, did that patient, those 5 patients, were they all seen on the same clinic day? So we do keep track of that. We've never had to use it, thank goodness. The history of present illness, the provider actually fills that part out. But then the nurse goes through the review of systems. And these are just quick drop downs of, you know, are they having fatigue? Are they missing any school, any work, fever? How's their cough? And it's very simple drop downs that they can click and go through very quickly. Again, with the provider in the room, the nurse practitioner, the physician we're standing by the back counter. We're trying to be really quiet, not interject. I have a problem with that sometimes, but we're hearing everything that the nurse is asking and what the patient is saying. The nurse also continues on our note and talks about their nutrition stuff. They ask what sort of airway clearance they're doing, what sort of exercise they're doing. And then what happens at that time is the nurse exits out of the patient's chart. She pens the note. There's a little symbol that comes up and said, do you want to pen the note? And then they switch. The nurse stands up by the counter and the provider goes to the computer, signs in, clicks on the patient's appointment. And there's a icon in Epic that says, make me the author, which is real important for the provider then to become the author of the note. And then the provider does his part, which, or her part, since I'm one as well, which is basically kind of going through the patient's problem list. And our note is if they touch the problem list, like they put in notation, it automatically gets pulled in the note. And it's kind of hard to see. It's the best I could do, but this is the button on icon where the provider clicks to take the note away from the nurse and make them the author. It's kind of like a half human with a star. And then, so that part happens in the clinic room. And then usually after, like in the work room, the provider finishes up and notes their physical exam. Again, these are drop downs to make things really simple. They do the assessment, the plan. This is where the problem list gets pulled in to the note, and they do the follow-up, do the billing, the diagnosis, and signs the note. So like I said, the two work together to complete the note. Lots of benefits we find to this partnership. For one thing, they're in the room together, so the provider is present to hear what the nurse asks, which prevents important information from being lost in translation or forgotten to be relayed when the nurse finally connects with the provider. The nurse then is in the room and they hear the provider's plan. So they, you know, as soon as the provider's done, she can sit right down. She can order, you know, whatever antibiotic the patient wanted, or needs. She can get the appointment set up, order any, radiology test in real time. And the patient's not asked the same questions multiple times and because they're there hearing each other's part. This has really reduced the length of clinic visits. As you can imagine, before when we didn't do the visit together, the provider would go in and apparently he told the patient, I'm going to give you some Bactrim. And then I'd go in to check the patient out and the patient would say, oh yeah, Dr. Murphy was going to prescribe me an antibiotic. And I'm like, okay. And so then I'd have to, you know, ungown, go find him, ask him that. So it really did cut back on the length of our clinic appointments. And we do this with other disciplines. I'm sure you guys do. Used to be like the dietitian and the social work would go in a lot, especially if the patient says, I have 10 minutes and I got to be out of here. So they'd tag team. My physical therapist was just telling me, it was mentioned in another session that a physical therapist and dietitians are going in together, especially if weight is an issue, so they can talk about nutrition and exercise. So just doing your best to sort of be respectful of the time that the patient is there. All right, that ends this talk. Teamwork's the best kind of work to get through a busy clinic. Who doesn't love a cute puppy and kitty? And that's how I think a lot of us feel after clinic. This is my wonderful adult team as well. We just seem all have wonderful teams, so they make all of these things in clinic work. And this is my contact information, and I'll take any questions.
Jill, I have a question.
Yeah.
How do you handle when there's a discrepancy between who the team feels like they need to see and who the patient wants to see?
Yes.
Sorry, I asked, there it
Yes.
is. How does their team handle when there's a discrepancy between who the patient wants to see and who the team feels they want to see?
Yes. So it does come down to some compromising and the amount of time. Sometimes it takes some education, like, we'll say, our dietitian or our social worker need to see you. And, they're like, well, I don't have time or I don't have any needs. And I'm like, they have to see you. We have to have annual notes by these patients for our accreditation. Now, that doesn't work for all the other disciplines because they're not required, but it does. It takes some talking, and sometimes if the patient has to go and they don't have time, we're like, okay, but next time you have to see them. So it's give and take. So, yep.
Hi, I'm Michael Blunden, one of the adult pulmonologists at Rhode Island Hospital. How do you make this work when you are having fellows, residents, med students, where then the shift from what has become kind of like second nature for us then has to shift to almost an N of one teaching model, which really kind of throws all of that out of whack.
Yes.
And kind of, screws the pooch from the start. So.
Yes. I wish I could tell you that our fellows spend a lot of time in adult CF clinic. They don't. They only spend, I think it's like 6 weeks for their entire 3 years of fellowship. So there's not too much, it doesn't shift it too often. In that case, some of this kind of goes by the wayside because the fellow actually goes in and does the whole note themselves because we want that to be a learning process for them, knowing what symptoms to ask. And like I said, we don't have fellows too often in clinic. We're trying to improve that, but yeah, it kind of goes by the wayside. Yep.
Hi, I'm Lily. I'm a nurse with the University of Utah, and I'm new into the CF world. So,
welcome.
I just have a question about your follow-up. When on the agenda, when a patient marks, or when the provider marks follow-up on this, with this at the next appointment, how do you track that and follow through with that? Because I feel like it can get lost easily in the mix.
Yeah, well, some of that, we have 2 CF nurses, and so there's always a CF nurse that's in the office or in the clinic room with us, and so they hear that. That's the benefit of having that nurse there. And I will tell you, we're just lucky. They are really good. They leave the clinic room and they write it down, and it just gets taken care of. I'm beyond blessed with what happens. So yeah. And like I said, a lot of that is because that nurse is in there hearing that the doctor said, okay, I want to get an abdominal ultrasound next time. And they're just really good about, making a mental note till they can write it down. Yeah.
Okay, so Rebecca asked, are the personalized CF appointment agendas scanned into the patient charts after the clinic day has ended?
It's not. Like I said, we just started implementing this, and it's not really an official form. It's just a worksheet for us and for the patient to use so that we're taking care of them, because we never did any of this before. And like I said, just came out of some feedback that we got that they just really want to know what's going to happen the next hour and a half that they're there. And if they see like 4 people are going to be seeing them, well, maybe they need to call somebody and say, listen, you need to go pick up the kids. I'm going to be here a while. So, but right now, no.
Delaney asked, how does this work for telemedicine visits?
We currently are not doing any telehealth medicine visits. So we serve the whole state of Nebraska. And we do an outreach clinic at a clinic halfway through. So we actually currently are not doing any telehealth. And so we don't have to worry about that right now. Yeah.
How does your team maintain infection control standards utilizing a waiting room versus having reception take a patient directly to a predetermined room? Do you have multiple waiting room areas?
No, we have just one. It's a very huge area and they can spill out, but we really encourage the patient to do e-check-in, which will even speed up the amount of time they spend. And then they don't sit down. The medical receptionist grabs them. They're not touching the patient, so it's not like they have to gown up or anything. But they, like I said, they don't sit down unless, does this work perfectly all the time? No, but I will tell you a lot of the times it does. Yeah.
Tara asks, any thoughts to add an agenda in Epic so they can answer during a check-in?
We have not thought about that with this. I know we're looking into that for smoking cessation. We do have something now, but it doesn't fit the needs for registry, but that's a really, really good point. And it'd be a good QI project, so thank you for that idea.
Brianna asked, does each provider have their own nurse go in the room with them, or is it one nurse for all the providers?
So I'll give you an example. So Monday is our busiest clinic day. We have 2 providers, which could be a combination of 2 physicians, or it could be a physician and nurse practitioner, and we have 2 CF nurses. And so typically they pair up, and that nurse kind of stays with the provider. For an example, I will tell you, like if there's a nurse that's on vacation, I will come over and be a nurse, so we still try to maintain that. That's the one thing about being a mid-level. You can sort of function as a nurse and as a provider, so that helps. If for some reason we don't have an extra nurse, then this kind of goes to the wayside. The nurse will interview still and start the note, but then they'll maybe step out of the room so that they can continue to answer calls and inboxes, but that's the rare occasion. The majority of the time we're paired up with a nurse and a doc.
Okay. Abby asked, our center nurses are reluctant to go in with the providers because they can feel like a scribe. Is there anything you've intentionally done to support your model of physician and nurse joint visit to ensure teamwork and job satisfaction?
I don't know, Stacy's in the audience. I don't think I've ever heard you guys complain that you feel like a scribe. And the other side to this is that if you're in the room with the doctor, and the next day or the next day after that, the patient calls and they are following up on something, it's great follow-up even after the patient has left clinic, because you're like, oh yeah, I remember you guys talked about this. So I guess I've never felt like I was a scribe. Stacy's looking at me. No, she doesn't either. So yeah.
All right, I have one more question, and there's several more that I have not answered. Once we get done with the speakers, I'll come back to it. So Haley asked, do all teammates in the clinic room go in the clinic room, or do they do their notes after coming out of the clinic? We struggle getting teammates to jump right into the next patient to keep the clinic moving.
Yeah, I can't answer for them, but I would think most of our clinic notes by the rest of the team are done after clinic. I don't think it's real time for their notes. Yeah.
Thanks so much, Jill. That was awesome. And then lastly, we have Kathy Vasquez. She is the program coordinator and respiratory therapist for the adult CF program of Central Texas in Austin. She has been with her center since 2018. She will be discussing incorporating quality improvement into your workflow. Let's welcome Kathy.
Okay. Hello, thank you all for coming. Like she said, I will be discussing how to incorporate QI into your workflow. I have no disclosures related. So let's get to it. Who has time for QI? Spoiler. You have time for QI. We all know that quality improvement can be very overwhelming. Some of us may shy away because we don't know where to start or how to even work through one. Don't worry, I'm not here to teach you how to work through one, just give you some tips and tricks that hopefully you can find a way to integrate it into your life. Yes, I did say life. So, where do I even start? Well, first you want to find a topic, one that piques your interest. There's endless ideas, just find one that fits you. It could be airway clearance, respiratory education, exercise, bone density, all kinds of things. If nothing comes to mind, you can always review your center's program report or hospital surveys or even XOCs through the end of the year since they are going away. When do I work on QI? Is it a bedside task or is it a binder task? Do you work on it during non-clinic hours, during clinic, or do you find yourself working on it during non-CF working hours, since not all of us work with CF 100% of the time? It's understandable that QI can feel like extra work. If you move it from the binder to the bedside, it does feel less daunting. So what should integration look like? QI should feel and look like daily work. It should be seamless. It should feel natural, kind of like autopilot. Don't think of it like a side project, but part of your routine patient care. Like checking emails or voicemails routinely. You want to have a feeling like data collection is a daily task. If you build it into your workflow, it will become part of your workflow, not parallel to care. Why is there a picture of a cheesecake on here? Well, think of it like a delicious turtle cheesecake. You can see all the different ingredients, but you want to taste it all together. So, why is integration so important? When you incorporate it into your workflow, it does not feel like you're doing that extra work. Again, you want it to feel like an everyday task. There's a greater chance of continued QI success if it is embedded into your daily practice. And consistent data collection and routine QI touches will increase chances of a project being cohesive and complete. Without that cohesion and completion, your project could be at risk for being fragmented, which can lead to time and effort wasted. So, how do you integrate it into your workflow? This can be a tough task depending on what type of project you're working on, but it's not unattainable. Some examples can include adding it to an existing clinic tracker spreadsheet. Apparently we all love spreadsheets, so it should be pretty easy to do. Or however your clinic is tracked. Add it to a survey on the patient's routine paperwork, just like Jill did. Leverage your team to maintain accountability. Make a checklist or a to-do list. Set deadlines for yourself, or add it to your weekly huddles. All right, let's take another look at it in a different way. Thanks to the handy-dandy AI tools, there's a convenient little acronym to help remind us how quality improvement can be successful. The next few slides will briefly go over that. We're going to start with some quick wins. We're going to involve our team. We're going to fit the flow. We're going to iterate. And then we're going to X-ray results. So what does that mean? For quick wins, break your project into smaller, manageable tasks. Don't try to complete it all at once. That can be frustrating. Look for slight changes you can make into your workflow. Small, consistent steps lead to significant progress for QI projects. Completing small tasks can give you confidence and build momentum for QI projects. An example can be dividing a cohort into small groups to complete data collection over a set period of time. For example, I'm going to collect data on 5 patients a day for the next 8 weeks. Many QI projects are completed over a longer period of time, so utilizing your extended time is very beneficial. Next, we're going to involve the team. Ask your team for help. If it's a joint project, don't be afraid to delegate tasks or volunteer for tasks. Even small contributions are beneficial. Nominate a cheerleader to help motivate the process and reinforce accountability. This person doesn't have to be involved in the project. They're just there to give you little pushes. Henry Ford said, if everyone is moving together, then success takes care of itself. We're then going to fit the flow. Look for the ways for it to fit into your current workflow to add that QI. Can you incorporate it with what team members are already doing? Don't add more work to work that you can just modify. Somebody once said, work smarter, not harder. It's a very popular quote if you haven't heard it before. Iterate lightly. We're going to keep it simple. Don't make too many changes at once. There was a study done where there's an article written for the Agency for Healthcare Research and Quality that stated, you will be making frequent corrections along the way as you learn from experience with each step and identify other actions to add to your strategy. Make small adjustments that can lead to sustained changes. It is okay if it does not work out. Another article by Barr and Brannon stated that small-scale projects allow for agile pivots upon seeing favorable changes. We're going to iterate on repeat. Sorry. QI is a continuous process, not a one and done. There are many ways to successfully complete a QI project. One method is using that PDSA cycles, the plan, do, act, study. It is okay to fail. Each iteration of the PDSA cycle improves upon the last one. Be the broken record, not only in project progress, but also in team motivation. The hardest part is consistency. It's like going to the gym. Once you overcome that initial fear and hesitancy, workload becomes more manageable and less intimidating. Again, providing confidence to keep going. X-ray the results. Well, what exactly does that mean? Look at your data or look at your results. There's helpful visual tools to included, but not limited to, run charts, Pareto charts. I always mess that word up. Pareto charts, fishbone diagrams, scatter diagrams, process flow maps, or even simple spreadsheets. You're going to share your results to sustain that QI effort. Quick updates during your current meetings to show that progress. This also allows you to see it from another person's perspective. Do they have ideas that can help you with your own projects? What kind of barriers do you have to QI? There can be various reasons why QI projects can be intimidating. Lack of training, lack of time, lack of ownership, lack of staff, lack of results, and so on. What are we going to do to bust these barriers? For lack of training, you can sign up for QI learning through the CF Foundation. There are various options available. Sorry, I have something else written. I just need to look at my little note. Or you can always ask around. There's several centers up here. Look, several centers that love sharing data. So you can always ask us and we can also help you. For lack of time, there's the daily integration is key. Add small tasks to your everyday work or current meetings. Lack of ownership. Again, don't be afraid to delegate roles and pick up responsibilities. Lack of staff. All right, this one might be above our pay grades, but if you include more disciplines in your projects, that might feel like you're helping alleviate the lack of staff issue. And then lack of result. Share your progress. Be proud of those small wins and learn from the small failures. So let's look at this in a practical application. Where did our program start? We actually started and we looked at our program report. We noticed that our advanced lung disease section could be improved upon. So our nurse practitioner decided that our program report showed that, again, our advanced lung disease should be improved upon. That was the next one. Sorry, guys. So what are we going to work on? Sending orders for echoes, VBGs, and 6-minute walk test. Ultimately, our goal is to get all of these tests completed. However, that depends largely on the patient, so we decided to focus on just ordering the test. Who was working on this project? The nurse practitioner, the doctors, the program coordinator, the nurses, the respiratory therapist, and the physical therapist. Our nurse practitioner is leading and collecting the data. The doctors are discussing care with patients and ordering missing tests. Our nurses are sending orders, referrals, and following up on patients. The program coordinator is also helping to collect the data. The respiratory therapists are running VBGs during clinic visits, as well as the physical therapist helping with 6-minute walk tests during those clinic visits. How did we integrate this into our workflow? Spreadsheets. We also love spreadsheets. We have 2 main spreadsheets for data collection. One during clinic days that is incorporated into our clinic flow board, and then one master spreadsheet to reflect all of our ALD patients. When are we working on this project? At least once a week. We have updates and discussions and included in our biweekly meetings. And then during our clinic flow prep, again, we go over it weekly as we prepare for our patients for that week. We're lucky to have a nurse practitioner that is solely responsible for our adult CF patients. So her and I usually chat with each other weekly on how things are going and to see what data we're missing. What is our current update? As of September 27th of 2025, our 13 ALD patients, 79% of them have had all 3 tests ordered. So how did we overcome some of our barriers? Again, the nurse practitioner took ownership of the project. We had slow results, but they were presented routinely during meetings. Why haven't we just ordered all of the tests for all of our ALD patients? Our center emphasizes shared decision-making with the patients, so we wanted to have that open communication during clinic visits. We're waiting for the patients to be seen, to have that discussion, and to answer any questions that might arise. If you want to know more about this particular project, our nurse practitioner, Christy Woods, is actually presenting it in Friday's workshop number 26, Leap into the Best Abstracts in Nursing. So in summary, QI should feel like daily work, not extra work. Small changes can lead to big improvements. Somebody said, failure is not an opposite of success, it's part of success. Remember that QI fix. Those quick wins, involve your team, fit the flow, iterate, and then x-ray your results. Collaboration, communication, and continuation are imperative to success. My references and any questions?
All right, Jill, this was back from before. What do you do when the patient's agenda does not align with the care team's agenda? For example, when a patient arrives to our clinic, they cannot pick what provider they want to see that day.
Then for me, I'm gonna sit.
Yeah, that is a real phenomenon that happens, that, you know, what we want to accomplish during the visit may not be what the patient wants to accomplish. Again, I think that it comes down to some education. There are certain providers that have to see you for our CF grant. It's just something that has to happen, not all the time. Some of it is looking into why maybe they don't want to see a certain provider. Kind of digging in that a little bit. Maybe they don't have time that day, compromising, saying, listen, I get it, you gotta go pick up your kid from daycare or whatever. Can we try and do this next visit? So it's working together. It's not a perfect science by any means. And you try to do shared, agenda making as much as you can, and just trying to educate the patient, so.
And Fred mentions that CFF has the Partnership Enhancement Program and to address agenda setting and co-production for clinic visits to center care on patients' needs. And if you haven't done that, it is a remarkable program. It really changes the whole perspective. Any other questions?
I did want to note real quick, we did get a question in the app and I answered it in the app, but in case anybody else is wondering, Jill's handout, you click into our session and then specifically Jill's part and look there and you'll see like this little paper looking icon, click on that and there's the handout, so.
Yeah, and I, because I'm old school, I did run off some paper copies, so if you want, just come up and I've got about 25 in my backpack, so.
Also a quick reminder, there is evaluations, like this 3-question evaluation in the app. Under the session, it's at the bottom, it says evaluation. So it's just, 3 questions, super quick. Please do fill it out and give us feedback. We'd really appreciate it.
And that's it. So if you want the copies of Jill's forms, please let us know. Come on up. She'll give it to you. You've got 30 minutes. We finished early. Thank you. Thank you so much.